Welcome to AETCM, the emergency medicine channel.
Yeah.
A 50-year-old male presented to ER with complaints of left flank pain since 1 week associated with vomiting. Initial 10-second assessment, airway patent, breathing, respiratory rate was 18 per minute, saturation 98% in room air, circulation BP 130/80 mm mercury, pulse rate 68, disability GCS 15/15, pupils bilaterally equal and reacting. Exposure temperature is normal. Pain score was 8/10, given injection PCM 1 gram IV stat. Adjuncts to primary survey, we had sent the
Okay. So we have, what is the age of the patient?
50-year-old male.
50-year-old male has come to you with an
left flank pain.
left-sided abdominal pain. Since when?
Since 1 week.
Okay. Since 1 week. Okay. 1 week. Okay. On and off pain since
and off
left. Can you explain regarding the pain a little bit further?
The pain was gradually migrating to left iliac fossa.
Okay.
And there was no associated chills and rigors.
Okay. There was fever?
Yeah, there was fever since 5 days, but now on the presentation he was febrile.
Okay. History of fevers 5 days back. At present he is febrile.
Febrile,
Okay.
and had vomiting episodes two
Okay.
episodes since on that date.
Okay. Okay.
Patient was evaluated outside and
Okay. Evaluation, let it wait. You tell me more about the pain. Continuous, intermittent, associated diarrhea, vomiting, all those things.
Pain was intermittent colic type pain, and there was no associated diarrhea.
Okay.
Vomiting was present on the presentation.
So left-sided abdominal pain, left
Radiating.
iliac fossa radiation.
Relating to that.
So what will be your differential diagnosis at this point of time?
Can be ureteric calculi
Ureteric calculi, why it should have fever?
with any UTI.
So it's not a simple urinary urolithiasis associated with an UTI. What will be the most common left-sided abdominal pain for a male patient coming to you with acute abdominal pain? With few history of fever, on and off. What will be the other differential diagnosis that you need to think of? Left side, diverticulitis. So that is the next differential diagnosis that you should keep in your mind. So whenever you get a left-sided abdominal pain, as you said, one thing you have to think is urolithiasis. It's not a simple urolithiasis, probably associated with an UTI, or you can think of diverticulitis. But bowel and bladder was normal, but even in diverticulitis, you can have just fever and abdominal pain. They can come in. And on examination, what was the finding?
Those.
See, this is nothing to do with ABCD approach because the patient is straight away. That's why I went ahead with the next evaluation.
The abdomen was soft, non-tender, and no renal angle tenderness.
Okay. It was soft.
Yeah.
So what will be the finding in diverticulitis? There can be a left iliac fossa tenderness. Can be there. So whenever you see a left iliac fossa tenderness, you think that it can be again a 50-year-old male diverticulitis. Now, usually what will be the time when you will see urolithiasis coming to the ED? And it will not be like 5 days or 7 days duration. It will be an acute onset within last 12 hours, 6 hours. That will be the presentation. What is the time when they present mostly to the ED? It is during the summer time. Always you remember that it will be the maximum number of ureteric cal that you will be seeing will be in Kerala, especially it will be somewhere around mid-March till April, May. May will be the maximum time that we will see because that is the summer time here. Because of decreased fluid intake and all, there is more chance of precipitation. So that is the usual time. But here there is 1 week history. It's not doesn't 100% fit into an urolithiasis, but it can be an urolithiasis which is complicated to an UTI and he is coming to you. So left side abdominal. Then what will be the other differential diagnosis that you need to think of? Pyelonephritis, okay, but one thing that is negative is the flank pain. Tenderness is not there, but you might not get renal angle tenderness for all pyelonephritis. Technically speaking, you should get, but early pyelonephritis, just the perinephric stranding and all, you might not get. So pyelonephritis can be another differential diagnosis. One thing that is against pyelonephritis is that there is no fever now. Maybe he would have already received some antibiotic from outside hospital. That way the fever is masking now. So then differential others. So left-sided abdominal pain, what are the other possibilities? Simple colitis, that can be another option. But bowel and bladder looks okay. There is no vomiting or loose stools. So colitis. So these are the most common differential diagnosis. If it's female, again ovarian pathology we need to think of. Since it's a male patient, we are not considering that. And again, what is the other thing? Can it be a referred pain? That is the most important thing. Whether it is a referred pain that is causing from the testicles. So it can be a referred pain. So don't always think that an acute abdominal pain, the patient is coming, it is just the pathologies in the abdomen. Always think of whether that's an ovarian, the testicular pathology or any maybe a torsion. They might not be seeing the pain in there, or maybe an epidermoorchitis. But when you call it as epidermoorchitis, definitely the inflammation all would have set in, and patient will have definitely got abdominal pain. So this will be the usual differential diagnosis that we need to keep in mind. So with this background, we need to start evaluating the patient. So whatever be the thing, our first priority is to give the pain relief. That rightly you have given the pain relief. So how will you plan pain management in such patients? Abdominal pain is very common in ED. So how will you plan pain management?
By WHO
Okay.
step-ladder pattern.
Okay.
First, the paracetamol can be given, and mild NSAIDs in the
Okay.
second, then mild opioids.
So that's the standard regimen of practice. So this is like you can gradually go upon it. But when a patient is coming with severe abdominal pain, you need not wait till step by approach. You can straight away jump, and maybe you can give a higher dose of analgesic initially itself. And most importantly, what you need to say is that you need to give adjuncts also. It is not just giving an NSAID alone. It is not just giving paracetamol alone. Maybe an antispasmodic agent together. So depending upon the type of pain, maybe we need to add on an adjunct therapy also. So these things are very, very important. So WHO pattern we can follow. Maybe in this patient we can follow. But if especially in trauma patients, the patient is having excruciating amount of pain, an open fracture, there you cannot go by a step 1, step 2, step 3. We may need to start a high dose, maybe a fentanyl, 30 to 40 or 50 microgram of fentanyl with an antiemetic along with the paracetamol. So always think in terms of whenever you are managing the pain, what is the mechanism behind the pain. So if it's an inflammatory pain or it's a colicky pain, type of pain is very important. And you should be managing the specific type of pain. So that is the next important thing that you should. So we have treated him with paracetamol, and next important thing that we need to evaluate him why he is having abdominal pain. It's a common thing to come to the ED. So how will you proceed with evaluation? What all investigation that you wanted to send in him?
You can send CBC-CRP for
CBC-CRP to look for any inflammation. Okay.
Then RFT.
Renal function test, agreed.
Then urine analysis.
Urine analysis.
Then imaging.
Imaging, definitely an ultrasound abdomen is warranted, or an X-ray KUB, whichever you prefer. But I will say an ultrasound abdomen will give you more information rather than an X-ray. So can we get the finding? Any other investigation that you want to send in this patient? Maybe not initially, maybe definitely later on we need to send in. You said regarding urolithiasis, what is the most important investigation that we want to look in for?
Uric acid.
Uric acid. So uric acid also should be kept in mind. Any drugs that he is on? He is taking any medications?
No regular medication.
So why that question I have asked? So which drug can precipitate hyperuricemia? Any antihypertensive that you can suggest? So commonly used, 50 years, 60, any thiazides, hydrochlorothiazide. So that is a one drug that can precipitate hyperuricemia. So always keep this thing in your mind whenever you are treating. Acute gout will come to the ED. Acute gout, you are treating the acute gout, but again you are not removing the precipitating factor. The most common combination will be the patient will be on a losartan with hydrochlorothiazide combination, a telmisartan with hydrochlorothiazide combination. So this combination, either you need to remove the hydrochlorothiazide, that is very notorious to cause precipitation of acute gout. So that is regarding. So the uric acid you definitely need to send. Maybe after urine you can look for any calcium oxalate or any uric acid crystals in the urine, but many a times we will not get, but definitely you have to think in terms of uric acid. So these are the investigation. Can we know the result of this investigation?
My ultrasound abdomen showed left mild hydroureter nephrosis, possibly due to left distal ureteric obstruction.
Okay.
And we had done the WBC count was 8,000.
Okay.
Urea 14.4, creatine 0.98.
Okay.
Urine routine blood negative, colorless, pH is 7, no pus cells, bacteria is also absent. Then we had done a CT KUB.
Okay. So now why you proceeded with the CTKUB? That is my question. All renal colic patients require a CTKUB. So whom it is warranted to do a CTKUB?
There is obstructive features, hydrouretronephrosis.
So what was the significant hydrouretronephrosis? Mild. Hydrouretronephrosis is there and all. You can wait. Creatinine is normal. So you can just wait and you can conservatively manage the patient and you can ask him to follow up. That is enough. But CTKUB definitely when it is required, when two reasons, when you have another diagnosis in your mind, whether you have got something like a pyelonephritis, even pyelonephritis, you will be investigation of choice is ultrasound. So whether you are having any other diagnosis in your mind or you wanted to see where exactly, so because the hydronephrosis is to that extent and we need to plan whether the patient need a DJ stenting or all those things, then definitely a CTKB is warranted. Otherwise, routinely for a patient coming in with urinary colic, you doesn't need a CTKB. So when you will ask for a CTKB, when you will ask, the things will be whenever you see a significant hydrouretronephrosis in your ultrasound, or you can have another diagnosis that in your mind, whether the same patient you are thinking in terms of an diverticulitis, but here ultrasound itself have given you an idea. Maybe ultrasound is normal, so you are having some other differential diagnosis in your mind, then definitely CT is warranted. But routine, it is not warranted. So that is the one thing that you need to remember. But anyway, you have done with CT. So what does it showing?
A calculus noted at left VUJ, measuring 7 into 10 millimeter, causing mild upstream dilatation of left ureter and renal pelvis. Right kidney is normal.
Okay. So where all the calculi can get stuck?
Pelvic junction, pelvic brim, and then vesico-ureteric junction.
So that's a common area where we have seen this. So these are the three areas where there is, why these are the common area? There is narrowing of the ureter is there. So that is a common area, so where the stone can get dislodged and can cause further problems. He said diabetic or hypertensive? No comorbidity. Okay, fine. Okay. So what you have done for this patient now?
We had given a urology consultation and they had stone fragmentation using lithoclast and DJ stenting was placed.
It was placed. What was the stone size?
7 into 10 mm.
7 into 10 mm. So that is the definitely treatment for the UVUJ. Some stones, if it is like more than 0.5 mm and all, it will not get dislodged. So you need to go ahead with the lithotripsy and the treatment. So as an ED, the patient is seen. So maybe you don't have a urology specialist available in your hospital. So you want to refer this patient. So before you do the referral, what are the basic things that you do for this patient? You give the pain management. The next thing. Okay, medical expression therapy, but the size is little bit on the higher side, may not be helpful. Maybe if it is a very small size, you can definitely think of a medical expression therapy. So what is medical expression therapy? What are the drugs that is used for that? Tamsulosin. Then?
Any antispasmodic.
Finasteride. Okay, then? Urinary alkalinizer. Okay, so the main treatment is an alpha blocker. The tamsulosin or whatever be the drug is the main agent, and there is an also recommendation for a smaller dose of steroids also can be tried. There has been two different thoughts. You can give a smaller dose of drugs like deflazacort, where it can help in decreasing the edema, and as well as it will help in removal of the stone. Maybe it's all short-term therapy, like 3 to 5 days of therapy you can try, and you can ask him to adequate hydrate, and that stone might get passed on. So you wanted antibiotics or not? That is my question. Whether you want to give antibiotics or not to give antibiotics. Antibiotics, yes or no? Yes or no? Yes or no? That's the only question. Yes, you have to give antibiotic, especially if the patient had a history of fever and all. So maybe an quinoline. So that should be more than enough. Ofloxacin, norfloxacin, ciprofloxacin, or levofloxacin, or even your cefotaxime. Anything that can cover a gram-negative organism, you need to give him maybe a shorter span of time. But if we have UTI, if the patient definitely had UTI, how long you should continue therapy?
10 to 14 days.
If 10 to 14 days, it will become a complicated UTI, because always remember, male UTIs are complicated UTI. You need to treat for 10 to 14 days. And also, we have to look in for other features like prostate size also for this patient. If he can have a recurrent, not stone, he can have some other reason, UTI. I am telling about UTI, BPH, or if it is there, you need to treat them. So again, Weltam will be, that is Tamsulosin will be more than enough. And when will you start finasteride combination? When routinely in ED, somebody has come with acute urinary retention. Again, the same situation, no urologist available. You have catheterized the patient. So you are planning to discharge him off. Okay, you are known that alpha blocker. So when you will give alpha blocker? No, alpha blocker, finasteride combination. Usually when the prostate size is above 35 cc. You get an ultrasound done. If the prostate size is above 35 cc, that is the ideal recommendation to start either dutasteride or a finasteride combination. There are a lot of newer Silidocin, that is another agent that being used. Silidocin D, that's another combination. Then you have Weltam, that's the most commonly used brand. So this finasteride addition, when you do, when the prostate size is above 35 cc. So it's not an emergency thing, but when you are practicing this, you should be having this knowledge. When you wanted to discharge a patient with acute urinary retention, if it is above 35 cc, you can ask them. So what is this thing that you will give to the patient? What is the advice that you will give to the patient? When we have already told, not hydration. When you are starting Weltam and all, it's an alpha blocker. So first dose phenomena. So the patient can have significant postural hypertension. So that part you should be very much aware of, and you should be telling what all precautions the patient should be taken. And also we should be looking back his diet. That is not an immediate thing. Later on, maybe uric acid is high. So what advice, which all food items you should avoid?
Red meat.
Red meat, then? Can vegetarians develop hyperuricemia?
Green leafy vegetables.
Pulses,
Green.
protein rich, spinach, cauliflower. These are all got a lot of uric acid. So you cannot tell them to completely avoid. You need to have a dietary recommendation to that. And if you found that the uric acid is 8, what will be the other thing that you will add? Or to add a drug that can decrease the uric acid production, which is a drug that you can use, febuxostat. So febuxostat 40 to 80 mg, you can ask them, and you can ask them to review in further, and you can decrease the doses. And if he has stone, definitely he should be on febuxostat. But first time you are seeing a hyperuricemia without any symptoms, you can just ask them to do dietary modifications, and later on you can review him back. And most importantly, one more agent that we missed is alcohol. So that is very notorious to produce hyperuricemia. So these are the things that you should be avoiding. And for this patient, anyway, urologist was available, so they have taken him for a lithotripsy, and stenting was done. Okay. So because the size of the stone was a little bit on the higher side, so that's way it helped by doing a CT for this patient. When you take care of this, because of this, we could be able to see the stone size was high, and we could. But routinely, if you ask CT, what is the problem?
Radiation.
Yeah, it's a very expensive investigation. It's like 6,000, 7,000 rupees. You can treat the whole urolithiasis with 500 rupees medication. For diagnostic purpose, since you haven't got the needed thing in an ultrasound, you should be asking for a CT. So always you should have an definitive indication. This will be the indication that I will say. So routinely we don't need CT. So that practice is there still. Maybe couple of reasons why because we have already done an ultrasound, we know that it's a stone pain, but for patient they might not be satisfied, so they might be demanding more, so we want to buy some time. So maybe a CT, by the time they come back from the CT, everything is normal, they will have that reassurance. And also another person can review the CT. It's not an individual bias, then other person can review, and definitely we can say that where exactly the position of the stone is. But a good X-ray KUB, if you have got an ultrasound with an X-ray KUB correlation, if you are able to get a very good X-ray KUB, it is not very equivalent, but you can still manage if you are able to see an stone, because urinary stones are majority of the time you can pick it up from an X-ray KUB also. So Don't think that always it is just UTI. Any abdominal pain, we always think in terms of differential diagnosis. So diverticulitis is one differential diagnosis that we can miss in the ED. So you're thinking whether urinary tract infection, diverticulitis, this all will be, the presentation will be vague. You will not be getting exactly what is required. So always keep those things in your mind and evaluate. Okay, fine. Anything else that you need to add on?
Yes, there is a stone score.
You can tell. You can tell what is stone score.
Predicts the recurrence of kidney stone based on radiological criteria.
Okay.
Based on 5 criteria. First is stone size in millimeter square, then tract length, distance from center of stone to the skin, then obstruction, that is HUN, number of calyces with calculi, and then essence, that is stone density in Hounsfield unit.
So this is the chance of recurrence. So maybe in ED we don't need this, but maybe in a urology OPD you can use, but I don't think any of the urologists are using this scoring system for any of them. That's wherever you get a chance, we put a scoring system. So that's a part of it. Okay, fine. Thank you.